Good morning and welcome to Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. We have a scheduling change today. Dr. Marty Marin will be unable to join me as he is in transit to the European Heart Failure Society meeting in Lisbon, Portugal, where there will be a hopefully exciting weekend ahead for the aficamten team as they are going to be presenting some data at the ESC Heart Failure meeting. And yours truly is getting on a plane tomorrow night, and I will be there as well for this event. So I figured as the guidelines dropped this week, the updated 2024 AHA-ACC HCM guidelines, a lot of acronyms there, that I would take a moment this morning as it was already on the schedule. And even though Marty can't join me, I'm going to go over the highlights of the updates to the guidelines. This is not what I would call groundbreaking moment for HCM. This is a tweaking of the guidelines. There are some very needed additions to the guidelines in the past 4 years. So there was a big shift in the guidelines from 2021 with the first edition of the guidelines. And then the revisions of 2020 were pretty, there's a big shift in those from the first to the second. This is just a tweaking of items. And there are 9 amendments or changes or additions that are I would refer to as significant because it's some class changes and some terminology changes. But for those of us who are, in the HCM world every day, there's no big surprises here. There's no ta-da moment. It's just constant refinement of knowledge, and it expands. And my appreciation to all who served on the committee. We'll talk about that a little bit later because I've gotten some communications of concern on some issues. So we will be dealing with that offline. So I wanted to go over, not necessarily in order of importance, but let's start with the revisions to area 6.5, which is heart rhythm assessment. Heart rhythm assessment. So the change is taking from a 2A indication, and for those who aren't familiar with the indications, a 1 is got the most support, 2A is, for lack of better terms, a could do, or maybe even a should do, or should consider, and a 2B is a could consider, and a 3 is does harm. So 1, 2A, 2B, and 3 are the numbers. So in heart rhythm assessment, the assessment for follow-up of atrial fibrillation in patients with class 3 to 4 heart failure, you should be doing the initial evaluation on a, quote, periodic follow-up. That was the old guidelines. The new guidelines recommending extended ambulatory monitoring for AFib as an initial part of evaluation and an annual follow-up. So there's some clarity in how often we should be looking for atrial fibrillation. And for patients out there who have already got a device, it may not be set up to detect AFib because that can take a lot of battery life. So you want to talk to your team about maybe wearing a patch monitor for a period of time every year to look for underlying AF so you can save some battery. Number 2 is regarding pediatrics. And it's a class 1 indication that in pediatric patients with HCM, regardless of symptom status, exercise stress testing is recommended to determine functional capacity and to provide prognostic information. That's in 6.7 under exercise testing. It was silent on pediatrics previously. A revision in the area of 7.2, which is patient selection for an ICD. So there was some age requirements and it was a 2A indication. The old guidelines stated that for patients under 16 with HCM and 1 risk factor, discussion of the 5-year risk stratification should be discussed as part of shared decision-making before placement of an ICD. This has just been opened up to say for patients with 1 major risk factor, and it removes the age on that. And it is still a 2A. Probably the one that's nobody in this community is going to be surprised at is in section 8.1.1, which is pharmacologic management of symptomatic patients with obstructive HCM. Can anybody guess what's coming here? Yes, mavacamten myosin inhibitors have made the guidelines as, I'll read the old and I'll read the new. So the former guidelines read, for patients with obstruction who have persistent severe symptoms attributed to left ventricular outflow tract obstruction despite beta blocker, calcium channel blocker, and disopyramide combination or single therapy, SRT can be performed at experienced centers as recommended, and that was a class 1. It is added that adding a myosin inhibitor, adult patients only, can be considered, and that is a class 1 indication. So myosin inhibitors are officially in the guidelines. There you go. That's probably the most significant change in the guidelines in terms of adding a therapeutic option onto the table, but it still does specifically state SRT is going to be considered, experience center is recommended. New addition, section 8.2, management of patients with non-obstructive HCM and preserved ejection fraction. This addition has the lightest amount of evidence. It comes in as a 2B, which is it could be considered for younger patients under 45, patients with non-obstructive HCM due to pathogenic or likely pathogenic sarcomeric mutation and mild phenotype. So this is a very specific family history kind of managed group of people, I would say. Valsartan may be beneficial to slow adverse cardiac remodeling. It's a 2B, it's light data, so I'd like to see some more on that before that becomes, obviously it's a 2B, it's at the right level. Okay, the next area is also new, and this is management of patients with HCM and advanced heart failure. So what we would previously have called burnt out HCM or end stage HCM, and had bad names. Advanced heart failure sounds better, even though it's still a little rough for those of us who've been there. In patients with HCM who develop persistent systolic dysfunction, EFs below 50, cardiac myosin inhibitors should be discontinued. So when you take that turn, it should be discontinued. Probably the other area that's not a surprise to be added in here is in 9.1 on recreational physical activity and competitive sports. The 2B recommendation from the 2020 guidelines, this one's a bit long, but I'm going to read it. For patients with HCM, participation in highly intensive recreational activity or moderate to high intensity competitive activities may be considered after comprehensive evaluation and shared decision making, repeated annually with an expert provider who conveys the risk of sudden death and ICD shocks may be increased, and with the understanding that eligibility decisions for competitive sports participation often involved a third party, team physician, consultant, or other institutional leadership acting on behalf of a school or team. So that was a 2B in 2020. This has changed and it's split now. We've got a 2A and a 2B recommendation under recreation. The 2A, which again has that higher level of data supporting it, states that for patients with HCM, participation in vigorous recreational activity is reasonable after an annual comprehensive evaluation and shared decision-making with an expert professional who balances the potential benefits and risks. That is now a 2A. The 2B, which is less data, for patients with HCM who are capable of high level of physical performance, participation in competitive sports may be considered after review with an expert provider with experience managing athletes with HCM who conducts an annual comprehensive evaluation and shared decision-making that balances the potential harm and risks. There are only a handful of HCM sports cardiologists out there. I think they're going to get a little bit busier based on these guidelines, but we recommend you lean into their expertise as they could provide some guidance here. The other two are new areas, recreational physical activity with competitive sports, again in 9.1. Again, not a big surprise, but I'm happy that it's in the guidelines written this way. For most, not all, for most patients with HCM, universal restriction from vigorous physical activity or competitive sport is not indicated. I just want to make sure that everybody hears that correctly, that on the opposite side of this, universal restriction is not indicated, but universal approval is not indicated either. So again, comprehensive consult with an expert to ensure that the anatomy, physiology, family history, individual history, all factors have been balanced with the sport or activity the individual wishes to participate in. There's a difference between sports and there's a difference between effort, and we want to make sure that everything is being clearly evaluated. But it's not a universal, no, you can't. But some of you still may be getting the, no, this isn't a safe answer for you. So I don't want people to hear universal restrictions not indicated to mean the converse, that universal approval is appropriate. So just remember, it still matters on your your physiology, your anatomy, your treatment, etc. The next area is under an area that has developed quite a bit over the past, 5-6 years. It got mentioned first in the last guideline, then we're refining it here, and that is pregnancy in patients with HCM. This is a cause of harm warning that there can be birth defects in women who are pregnant and on mavacamten. So you'll want to really think about your treatment options if you are a person considering pregnancy and also has obstruction. So surgery may be the better option to get you through those childbearing years, and additional therapy may be needed later. That's not what the guidelines say, that's what Lisa says, and that's what we see practice all the time. So be careful with the pregnancy and mavacamten. In the event that you happen to be listening to this and you are taking mavacamten and you do get pregnant, whether you're in a clinical trial or whether you are on labeled indication, mavacamten, Camzyos, if you develop a pregnancy, there is a pregnancy registry being maintained by BMS. So make sure that if you do find yourself pregnant on a myosin inhibitor, that you make sure that your doctor is notifying the study team at BMS to ensure that the pregnancies are recorded and we can track what is happening with these women and what the burden is to an individual who encounters a pregnancy anywhere in the United States in 2024 while taking a myosin inhibitor. If anybody needs assistance or has questions about this particular issue, I encourage them to reach out to the office, and I'd be happy to speak to you offline on that. Pregnancy is important to a large percentage of our population, and we need to, not only through the guidelines, but through general advocacy, remember that this is a very, very special group of individuals who require our attention and our focus, and they require, in some cases, some bodily autonomy that may not be available in every state in the country right now, which is highly problematic for those who may not be able to successfully carry a pregnancy. The good news is most women with HCM can successfully carry a pregnancy. Some of you may not be able to. So I encourage you to have a really deep conversation with your healthcare providers about your family planning options and make sure that they are supportive of your wishes and the community in which you reside in 2024. That's what I've got hot off the presses here. Guidelines came out earlier this week. I just got a note from Marty. So what we're going to try to do, he's already in Lisbon. I don't leave till tomorrow night. We're going to be getting together after the presentation. So I think I'm going to try to find a quiet little spot. I'm going to bring some equipment with me, and maybe Marty and I will do a podcast from Lisbon, Portugal, and we'll give you the late breaking data from the CITO trial as soon as we are out of embargo on that. That'll be super cool. And we hope you join us for that. Unfortunately, we've run into some problems. Obviously, you can't hear me right now if you're in the private Facebook group, but there's been some changes at Meta and we're not able to live stream in the private groups anymore, only on the pages. So hopefully they'll come up with some security connections so we can go back to doing the podcast live from that space. There was another thing I wanted to bring up. I know what I wanted to bring up. We're going to pivot into a very different direction. And you're going to see me actually wearing exactly what I'm wearing right now because I recorded it just a few minutes ago with a call to action for the community. One of our own needs a little bit of help, and this is a little off the typical. So regardless of where you're hearing this, I'm going to snip this piece into a shorter version basically and share it through social media. And I'm going to ask that you share that. Story time with Lisa. One of our community members, one of our ambassadors, is a name that some of you in the community may be familiar with. Her name is Debbie Hamilton. And Debbie is married to Lou, and they live in Suffolk County, Virginia, where they reside with their 9 miniature horses, 2 regular size horses, and a couple of cats. And currently, Debbie has been readmitted into Cleveland Clinic, and her donor heart of about 3 years is failing, and she will be listed for retransplantation. Obviously, this is highly disappointing for everybody involved in this situation, mostly Debbie and Lou, but also to the donor family who they have a relationship with, and to all of the healthcare workers that worked very hard to keep this heart moving and going. Debbie has had some significant challenges, but it looks like we're going to go to second transplant, and they will be meeting on official listing very shortly. So I asked Debbie, what could we do to help her out during this very challenging time for her and Lou? And it wasn't what I expected. And I said, honey, I don't know if I can deliver on this one, but the internet is cool and we have a lot of friends out there, so I'm going to try. Lou has been traveling back and forth between Suffolk County, Virginia, and the Cleveland Clinic, driving back and forth. So the HCMA is hooking him up with Angel Flight so that we can get him some flights back and forth to be Debbie's caregiver. That's part of the program that we set up with Angel Flight, and we're really happy to have that. But there are horses in Virginia that need tending to. They need daily feeds, they need daily watering, and we're trying to reach out to people in the Suffolk, Virginia community, my horsey people. For those of you who don't know, my daughter and my money went to the barn for most of my child's adolescence, and she still is a barn girl. I've been a horse mom, and the horse community is a tight community, but I don't know the Virginia horse community. But people know the horse community. And if you are a member of a horsey family in Virginia and you have friends who know how to grain a horse in the morning and put some feed out and check the water and keep them safe, we need some volunteers. I need volunteers in Suffolk, Virginia to help Lou and Debbie with the horses while she focuses on recovering. So why are her horses just more than pets? Well, she uses some of them as therapy animals to help others. Why would I put this call out for Debbie and Lou? Not only has Debbie been a part of the community as a Facebook moderator and as a member of our patient ed committee, she also, after her transplant, went back to school to become a social worker and to be able to help other families going through battles with chronic illness. And she'd love to be able to get back to doing the work she wants to do, but this heart isn't going to let her do it. So while she fights for her life and a new heart, let's try to find some people in Suffolk, Virginia to help with the horses. Why not? All it takes is some people who give a damn and have a little bit of time to give. And if they happen to be in the area, maybe 4-H, maybe a county program, maybe somebody has a resource. I'm putting it out to the universe. Let's do some good things for her. So that's what I've got. Okay, a couple of other announcements before I go. If you are in the Portland, Oregon area, we are going to be in Portland on June 14, 15, 16 for a conference of the American Society of Echo. And if you are a patient who has obstructive HCM or provocable obstruction, and you are interested in helping educate sonographers, there's going to be a live exhibition, Modesty Will Be Protected, where you will help sonographers understand how to do a proper Valsalva and get that peak gradient. We've already got 3 volunteers signed up. I got another space or 2 for 2 more. If you are in the area, we'll give you a hotel night. I don't unfortunately have a budget for travel in, but if you're in the area and you want to stay over, we're going to host a little meet and greet one night, and we will be happy to meet you out there. So if you're interested, please send us a note at support@4hsam.org or call the office 973-983-7429. So that's another upcoming event. Again, I will be over in Portugal for a couple days at this conference, and then back to the office, and then back up to Boston, and then out to Portland, and then Seattle. We're coming to you in July as well. So hopefully we'll pull together a nice meet and greet for our folks in Seattle. And I will also be at the Heart Failure Conference in San Diego in July. And then back in London for ESC London, and that is at the end of August. So there's a lot of travel coming up, and it all leads into our annual meeting in October, which is tied to the International Summit 8. So the summit is Friday, Saturday, Sunday morning. HCMA will be participating at Saturday night at the summit for patients and the participants at the summit, as well as a couple of very special guests that we're planning. Can't give away all my secrets, but there'll be a tearjerker, I promise you, and a lot of inspirational stories shared. So that'll happen at Saturday night at the summit. And then at 1:45 Sunday afternoon, we pivot from the summit to the HCMA annual meeting, which will run a little bit odd hours. We're going to run from about 1:45 to 7 p.m. and then there'll be a dinner afterwards. We will also have clinical trial recruitment rooms available for some of our sponsors and for patients to learn more about their trial opportunities, which are going to be increasing in number. So to all of you who've come to the table with wonderful new concepts on how to manage HCM, we are here to help connect those patients with those trials and help deliver science as quickly and safely as possible. So we thank you for that. We've got a lot of other stuff coming up in the next couple of weeks. So stay tuned. Our report from our clinical trial endpoints meeting from October, it's a little delayed. Sorry about that, but that will be made public very soon. life got in the way of that one. Every time I tried to have my meeting to go over the drafts, I ended up in the hospital. It was the food poisoning in December. It was the pacemaker in March. And every time we tried to get on calendar, I ended up in a hospital. I'm happy to say that the report is at 99% completion and I'm not in a hospital, which is a good thing. All righty. So I thank you all for spending a few minutes with me today. I'm going to get off to some other things today. If there's any other questions anybody has, they know where to reach us. So thanks for joining us on this edition of Tales from the Heart, a podcast from the HCMA. Thanks to all of our sponsors. The ad will get dropped at the end, and we really appreciate you guys. So tune in next week at some point. As soon as I can figure out when I'm going to do the podcast with Marty, I'll let you know, and we'll hopefully be live from Lisbon, Portugal. Take care. Bye-bye.